Well, for those of you that were able to navigate today's call, thank you. And this call will be recorded so that others can download it and listen to it as well. So the purpose of this call this month is to talk about eye problems that can be detected through EyePACS beyond just diabetic retinopathy. And we've been doing some work over the summer, and we would definitely like to hear your recommendations, your questions, and your concerns about expanding our current program for diabetic retinopathy beyond to other conditions. And let's see here. All right. So we know that the diabetic retinopathy is the main cause of blindness for people between the ages of 25 and 60, 65 or 70. But it's not really the main cause of blindness. More people will become blind from other conditions like glaucoma and macular degeneration. But our program right now, the way it's set up, isn't really set up to be able to detect those in a reasonable way. We do find people with other conditions and we refer them on, but we need a systematic approach to do that. And that's, I think, especially important because the majority of these conditions can be prevented with early intervention, or can be at least maybe not completely prevented, but can be made delayed, or the consequences wouldn't be as severe if we had early intervention. So many conditions are being detected already through EyePACS, and we'll talk about how we can systemize that, make it a little better. So right now, about 8% or so of patients that are screened in the community clinics have sight-threatening diabetic retinopathy. We know that a lot more have retinopathy, but only about 8% are really at a stage where they're at risk of losing sight because of their retinopathy. And let's see, but about the same proportion of EyePACS cases also result in referral for sight-threatening conditions that are not related to diabetic retinopathy. So in order of prevalence, the referrals that we get are for glaucoma, cataracts, macular problems in the retina, problems with the optic nerve. Sometimes we get pigmented lesions, and sometimes we get these retinal degenerations. A lot of times they're hereditary. Sometimes they're induced by medications that are prescribed. And all of these also need attention. So going on to the next slide. Oh, by the way, this particular case, I don't know if you can see it very well there, but this is a patient that had a cataract and no other problems really, just needed to be operated for the cataract. So I wanted to do a poll, but I think we'll need to wait on that for another time. But I wanted to ask and get information from the clinics about, what's the time frame that your clinics have to handle eye exam referrals. So if a person comes in with a complaint about an eye problem, how soon can they get in? And if anybody wants to just speak up and say, how long it takes to get a patient in, and if there's a way to separate those that have urgent problems from those that don't, that would be great. And if you don't, I'll just keep moving on, and hopefully we'll get this information. Maybe we'll do a survey separately to the users, the EyePACS users, at a later time. But yep.
This is Michelle from Brawley Clinic. We normally, if the provider says that the patient needs to be have a retinal scan, at the moment after they're being seen, they're sent to have the retinal scan.
Oh, okay, great. And then what about from the retinal scan? Let's say that something comes in abnormal. Then what's the wait time to get a regular eye exam? And is it possible to differentiate the wait times depending on how urgent the referrals indicated on the report?
We have a specialist that comes in twice a month, and let's say if as soon as we receive the abnormal results, we go ahead and schedule our in-house appointment with our specialist.
Okay.
And
so
that would be the week after, at most 2 weeks.
Wow, that's wonderful. So Dr. Mani, I guess, is your specialist there?
Yes, he comes in every other week.
Every other week, and so then those patients, the most that they're going to wait is 2 weeks.
Yes.
And if there's an indication, say, on the EyePACS report that the patient needs to be seen the next day, is that something that's managed also through the referral system?
Yes. What we do is then call his office and see if the patient can be seen in his office the next day, or at most whatever they have available.
Okay, great. Yeah, and I'd love to hear from any of the other people on the list to see if there's any different way that you manage the patients. I know in some of the counties they have no choice but to just put him pretty much in line for the next appointment, which could be months later. And we're hoping to be able to change that. But anyway, yeah, thank you for your input. And let me just keep going then, and we'll talk about some of the other things that have come up. Another question that I'd like to ask the clinics is, what is your average waiting time? And I got your answer there, Michelle. Thank you. But anyone else, if you'd like to tell me which category your clinic fits into here, that'd be great. And if not, then I'll just keep going. And let's see here. But I'm going to send this out as a survey. I think that'll be important information for us to get. All right. All right. So anyway, the challenge for dealing with other conditions besides diabetic retinopathy is that we don't really know how sensitive and how specific the referrals are, because that work often hasn't been done like it has for diabetic retinopathy. The whole world agrees about how to diagnose diabetic retinopathy. They know, they're pretty much in agreement on the risk, depending on how severe the retinopathy looks, the risk for vision loss, and when the patient should be treated. That's not true for any of the other diseases, even cataracts. Glaucoma, certainly, there's a lot of disagreement about when to call it glaucoma and when to treat it. So the other thing, too, as we reiterate over and over again, is that the retinal consult doesn't take the place of a full eye exam. So it's not that we want to design something that'll just not require people to get an eye exam. They'll still have to get an eye exam, but we know that the reality is that often, the possibilities of a general routine eye exam isn't all that available to them. At any rate, so what we hope to do over the next few years is to be able to validate some system that we can come up with for other conditions besides diabetic retinopathy. We need to make sure that the consultants are interpreting the images in a consistent way so that there isn't an excessive amount of disagreement or variability in the way that they provide recommendations about when to refer and how soon the patient needs to be treated. The other thing that we're also battling with is that when you refer for other conditions, sometimes the treatment isn't as effective as what we have for diabetic retinopathy. We know that if we can get people into treatment for diabetic retinopathy early, that the vast majority are able to preserve their sight. We know that that's not happening. That's a project that we're wanting to improve to make sure that everybody that's in sight-threatening, has a sight-threatening condition gets treated for diabetic retinopathy. But we know that if they do get treated, their vision's saved. That we can't say for other conditions like macular degeneration. There are treatments. We know that they're effective, but they're just not as effective as the treatments available for diabetic retinopathy. And we also want to avoid the problem of excessive over-referrals, because if there's just a minor suspicion that a disease exists, then it really. All right, let's see, that was somebody's phone. Okay, I'm going to continue on. Yes. Do we have a question out there?
No. I think it was an error.
Okay, all right. Anyway, if you do have a question, please feel free to speak up. The other problem is excessive over-referral is what I was talking about. And sometimes those can be rather dramatic. For example, with pigmented lesions, if you're suspecting that it's some type of ocular cancer, that could be life-threatening. But at the same time, we know that the vast majority, 99.99% of the pigmented lesions are not going to be melanoma, for example. So how do we manage those issues? And we're not alone in trying to figure out a reasonable way to deal with those problems. Prevent Blindness America is interested in being able to, of course, prevent blindness by early detection in adults and in children. And the Northern California chapter has taken on the task, to see how retinal imaging fits into that for adults. So they created a task force and a scientific committee to be able to come up with a reasonable approach to detecting sight-threatening changes beyond just diabetic retinopathy. So, and their purpose is to make sure these people don't go blind, right? So they're not as interested in finding the very beginnings of some slow-moving eye diseases, like glaucoma, for example, often moves very slowly. They're not interested in finding the person that's just starting glaucoma. It'd be great if you could, but what they're more interested in, because it's more reasonable, is to find those patients that have established glaucoma and could lose sight in the near future. And how do you partition those from those that can go on for several years more before suffering an vision impairment? So what they wanted to do was develop a protocol to be able to get the necessary clinical information and combine those with the images that we're already getting for the retina to have a consistent and easily adapted detection system. And I want to underscore the easily adapted part of this. It has to be a system that works well in the workflow. What they're interested in is actually in screening environments, but this can also be adapted to clinical environments like our community clinics. And that's why we're just really fortunate and grateful that this group of extremely well-respected committee members have been able to come up with at least the beginnings of an approach for non-diabetic problems. So the idea then is to create an interpretation protocol for the consultants. And what was decided was, instead of differentiating into all the different diseases like glaucoma, like macular degeneration, like retinal hereditary problems, instead of that, what they focused on was just identifying sight-threatening lesions on the optic nerve, on the entire retina, and in the macula. And based on that, create a referral urgency grade, a risk grade that then can be passed along to the patient and to the clinicians that take care of the patient. So for optic nerve lesions, of course, there's some that are very specific for glaucoma, and these come up all the time. And they specified not the lesions that would just barely begin to show in somebody that's beginning glaucoma, but actually that would show when the glaucoma is full-blown and moving right along and is putting the patient in danger of going blind. They're also looking for cases where the optic nerve becomes pale. So a lot of toxic reactions, trauma, other things that happen to our patients in our community clinics can cause atrophy of the optic nerve, and that can be detected as well, we're hoping, through the pictures. And then papilledema is swollen optic nerves, and we've had a few of these, and they've been pretty striking. The picture that's in this slide right now is a possible papilledema that then would need to be referred immediately. the retinal lesions that we're going to be detecting through the system is, of course, diabetic retinopathy, just as we detect it now, including neovascularization. That's the growth of new blood vessels. We're also going to be looking for invasive lesions, such as melanomas. We want to be able to distinguish those from just, friendly pigmented spots and freckles and other things like that appear. Active retinitis we'll see sometimes in our patients that have toxoplasmosis or other blood-borne diseases, and those need to be taken care of right away. And of course, retinal detachments, which we've seen a few as well. Then, regarding lesions of the macula, the center of the retina, this is a little more complicated because here we're dealing with macular degeneration, which from just pictures isn't really, you can't really find all the people who are at risk. But we kind of try to do the best we can. We know that there's a lot of counseling that has to be done for our patients. And for those of you that are listening to this or going to listen to this presentation, remember that our younger patients can benefit quite a bit in their later life by protecting their eyes using sunglasses, not smoking, and eating well, taking antioxidants. And that actually has been shown to help to reduce the incidence of macular degeneration later in life. Of course, we want to find macular edema from diabetes and other maculopathies that show up from time to time. There's other referral criteria as well that is going to be helpful. We're still kind of wrestling about how to integrate these into a screening program. The Prevent Blindness Northern California Committee is including visual acuities, how well they're seeing the letters, and using that as a criteria for referral. Also recognizing that acute onset of pain and vision loss is always an indication for referral. And if this happens in your clinic, of course those patients can be photographed. Even though you're going to refer that patient right away, it would be good to have the interpretation just so that you would know immediately from our group of consultants, what might be going on with that patient. The other thing that we're looking to add is intraocular pressures. And that has been the subject of a lot of debate. I'm not sure that everybody is in agreement that intraocular pressure would really add a lot to the diagnosis or the referral recommendation. Only if it's extremely high, but even then there's questions. Also, another referral criteria, I guess this is more of a referral criteria for pictures, is the initiation of systemic treatments that are associated with vision loss. So if you have a patient who's starting Hep C treatment, for example, or starting Plaquenil or steroids, this may also be an indication for taking pictures, and then the referral based on those, on that situation of the patient then would be something that we would handle through the consultants. All right, so let's continue on. So what had been agreed by the committee in terms of the urgency for referrals, if a patient has swelling of the optic nerve, or if there's retinal detachment, there's new blood vessels on the iris, not so much on the retina, but on the iris. If there's an active inflammation in the retina, or if there's new blood vessels growing right in the macula, right in the center of the vision, if you have acute vision loss or acute onset of pain, severe pain, then those are emergency referrals that patients need to go within a day or two to have it looked at. Then there was this idea of urgent referral. So that's for patients that need to be seen within 1 month. So if you have optic nerves that are kind of pale, if you have the growth of new blood vessels in the retina, or if you have swelling of the macula and macular edema, or if you have a possibly invasive lesion, this pigmented spot that you think might be invading the retina, well, those would be referred within 1 month. And I just want to mention also, any of these referrals time periods can be overridden by the consultant. Sometimes it's obvious that patients would either need to be referred sooner or could be, followed by pictures, and that we leave up to the consultant as well. But we're forming these general guidelines so that there's more consistency among the consultants for doing the referrals. So moderately urgent referrals would be if there's optic nerve features that are blurred, if the visual acuity is less than 20/40. Even obvious glaucoma doesn't need to be seen immediately most of the time. So in those cases, then we allow a longer time period for the patient to end up in care. As we know, diabetic retinopathy, unless it's gone into the proliferative stage, doesn't need to be referred immediately, but does need to be referred for sure. And then lesions that are related with macular degeneration as well. We give a pass, and that means that the patient, still needs to get a regular eye exam, but doesn't really need to be screened for another year. If the media is clear, if the eyes look clear, if all the features are visible, optic nerves look good, the retinal vessels are sharp, and if all the things we're expecting to see are there. For patients that have non-readable images, those will not be used to initiate referrals. What we usually do now is what we'll continue to do is try to have the patient come back to get better images. If it's just impossible to get better images, well then those patients do need to be referred out for a general eye exam so we can see what's going on. So that's pretty much it. We're developing this into a new template that's going to show up in EyePACS, and we'll have more information for you later when this gets deployed as a module in EyePACS, we're hoping, within 3 to 4 months. We've been saying 3 to 4 months for a while, but this time we're getting pretty close. What we're doing now with vision screenings that are done by Prevent Blindness America, we're validating this protocol to see how well it performs. We are very interested in getting primary care providers more involved in being able to look at the images and identify those lesions as well. That makes for very effective triage. For example, if you have an emergency case and you have the provider there, but you're not quite sure when the EyePACS read is going to come in. We know that that doesn't take the place of the diagnosis, but it sure helps to make things move a little quicker. We're continuing to work on automating and integrating all of our modules into so that it communicates with electronic medical records and referral systems. When it comes to a broader blindness prevention program, I think it really makes a big difference. We need to also create more contact with the ophthalmologists who will actually be treating the cases that you refer from EyePACS. We would love it to have them log in or be able to follow a link in their email so they can actually see the cases themselves if they want to. And a number of them have expressed interest in seeing that. We're pretty excited about some new developments in EyePACS that would allow your clinics to be able to automatically contact patients if there's an urgent referral that's needed, or if they're due for imaging once again, maybe via a text message to their mobile phone, things like that. I think with most people having mobile phones, that's a possibility. We know that it's not possible in all community clinics because of the reliability of the phone numbers that you get, but it may be something that's useful for some of the clinics. The other thing that really excites us is for primary care providers looking at the images is that we may be able to identify risk factors and biomarkers for other systemic diseases, cardiovascular disease, nephropathy, and other conditions that doesn't need an eye referral, but could be effective and important for the systemic care of the patient. And lastly, there's some new automated computer programs that may be able to help out with the triage or suggest things that we can start instituting into the program. So on that note, I just want to say thank you, and I'll take any questions. And we are a bit past our time.
I have a quick question. This is Adam Sussman from Lifelong. So this looks really great, and I love how there are now these very different categories for different conditions. Are you guys actively working with places that we refer patients to educate them on this new system that you've created?
We're not at that stage yet, Adam. We need to deploy this out and validate it, and then we'll be actively telling the whole world, about how this works. Hopefully, in coordination with the organizations that are helping us to put this together, like UCSF and Prevent Blindness. Yeah.
Great. So it just so I understand, there's no direct linkage work happening yet with these efforts.
You mean for treatment?
For treatment, yeah.
Right. No, the treatment. This goes across the board throughout all the clinics across the country and in Mexico and other places. Is that they use their already established referral network. The clinicians that work with them for eye care are the ones still referred to. And that is a problem. We've been working with the clinics to see what we can do to get more resources in there. But if only we could provide the treatments through internet, that would be wonderful.
Yeah.
Have the patient come up to their computer and have laser treatment, but we're not there yet.
For sure.
Yeah. Do we have other comments, questions? All right. I'd like to thank you very much for participating. Usually at this point, we announce the winners of the clinics that have done the most and screened more patients and most improved and things like that. Unfortunately, this time I don't have the numbers, so please stand by and you will get an announcement through email. All right. Thanks again for participating, and next time around, you should have a much easier time connecting through the same site. Have a great day.
Thank you, Dr. Cordros.
Bye-bye.
Thank you. Bye.
Bye.